The question whether to operate a patient with acute endocarditis is always a very, very difficult issue. It often mounts into a battle between the surgeons and the cardiologists. The surgeons want to wait, while the cardiologists want to operate. But I guess both approaches have their advantages and disadvantages. If we wait too long, we risk embolism and spread of infection. And it is also not so easy to operate a patient who has acute infection because sutures don't hold and the patient could get more septic. So in reality, it's always a decision which has to be individualized to the patient, to the underlying problem. But see for yourself in this chapter how you would go about and what the guidelines say in how to treat patients with acute endocarditis. The decision-making whether or not you should operate a patient is always a matter of weighing the risks of infection and complications, of course, versus the risks of surgery. Basically, you always have to use some form of individual assessment because every patient is different. And I've seen patients who I actually thought should be operated, but then they did fine just on antibiotic therapy. Unfortunately, if your decision was correct, only turns out afterwards. So retrospectively, it's always easier to know if you did the right thing or not. But to just give you a better feeling for how high the risk of surgery is, here is the mortality data. Approximately 5 to 15% of patients die. Now, of course, you have to weigh that against the risk of not operating, and remember, endocarditis itself has a fairly high mortality. The risk of perioperative valve dysfunction is 7%, and the reoccurrence rate is 12%. But what is the risk of not operating, of waiting too long? Well, uncontrolled infection with sepsis, all the complications we listed in the previous chapters, and embolism. Especially high, of course, is the risk in the setting of prosthetic valve endocarditis, in-staph aureus infection, and in aortic valve endocarditis. According to the ESC guidelines, which were published 2009, one can classify the reasons to operate into 3 different categories. The first is heart failure, either caused by some form of acute regurgitation, either mitral or aortic. Fistulous communications, in other words, some hemodynamic sequel which causes heart failure. And poor hemodynamic tolerance to whatever the problem is, basically. The second group is comprised of those patients who have uncontrolled infection, either locally, in other words, abscess formation, pseudoaneurysms, fistulous communications, or enlarging vegetations, or those who have persistent fever and positive blood cultures for more than 7 to 10 days, or those patients who have a very pathogenic bug such as fungi or multi-resistant organisms. And finally, the third group of patients are those where we want to prevent embolism. Usually patients who have large vegetations, and I would also say very mobile vegetations, and especially those who have already had some form of embolic episode. In summary, you should think about operation in those patients who have hemodynamic problems, uncontrolled infection, high risk of embolism, and especially in those patients who have prosthetic valve endocarditis. Remember, the timing of operation is also important. Sometimes you will have to go for urgent surgery. Sometimes you have a few days or weeks, maybe even to wait. What are some surgical considerations? Well, first of all, no surgeon likes to operate a patient who is in sepsis, because usually you have a lot of postoperative complications in these patients. Second, you need to resect the infected tissue, so that leaves you with a defect. So there has to be a significant amount of reconstruction done to allow you to implant another valve, for example. Third, especially patients who have already been operated have a lot of adhesions which can make operation very difficult too. And then finally, many patients with endocarditis have both left and in particular also right heart failure. But in conclusion, one thing to remember, if the patient really deteriorates, you have to be quick. You have to operate the patients before the break of dawn. Okay, so now we're done with this very long chapter on endocarditis. Don't forget to go to the summary slides because I provided a lot of information to you and it's good to review all this information. And then don't forget to also go to the atlas. There's a number of cases in there which I haven't shown you in the presentations yet.